Welcome to today's deep dive. We are tackling a mission today that affects millions of women, but honestly rarely gets unpacked in a typical clinical setting.
Yeah, it's definitely something that flies under the radar.
Right, so we are answering the question, can a standard postnatal check completely miss vaginal laxity?
And spoiler alert, the answer is going to surprise a lot of people.
Seriously, we've pulled from a massive stack of diverse sources for this. We're looking at the NACE guidelines, the National Institute for Health and Care Excellence, plus, comprehensive reviews from the Royal Australian College of General Practitioners.
We also brought in some highly specialized pelvic physiotherapy protocols and some really groundbreaking academic imaging studies by researchers like H.P. Dietz and K. Van Delft.
Yeah, the imaging data is wild. So whether you are a new parent, an expecting mother, or just someone fascinated by the biomechanical realities of women's health, this deep dive reveals a massive gap in standard medical care.
It really is a profound gap. I mean, the data we're looking at fundamentally challenges what a clean bill of health at 6 weeks postpartum actually means for you.
Because usually, when we talk about a medical diagnosis, there's this expectation of precision, right? Like if you break your arm, the x-ray shows a jagged white line, the doctor points to it, and well, the path forward is clear.
Exactly. You get a cast, you get physical therapy.
But then you step into the world of postnatal recovery, and suddenly that x-ray machine feels like it's broken. We're looking at a diagnostic landscape that is just incredibly murky. Okay, let's unpack this.
Let's do it.
Before we can figure out how a major functional issue like laxity flies under the radar, we have to look at the baseline. So what is the standard 6-week postnatal check actually looking for?
Well, if you look at it from a purely medical perspective, based on those NICE protocols you mentioned, the 6-week check is really just an assessment of acute healing.
Acute healing.
Yeah.
Like life or death stuff.
Right. It's baseline stability. The GP or the OBGYN is running through a very specific checklist. They're screening for postpartum depression, checking blood pressure, mostly to rule out lingering preeclampsia, and, verifying that the uterus is contracted back into the pelvis.
And checking that the bleeding, the lochia, has stopped. Right.
Exactly. They just want to make sure you're not bleeding out.
So they are essentially just looking for red flags.
Yeah.
Making sure perineal tear or like a C-section incision isn't actively infected.
Yeah, I mean, consider the internal physiology of what just happened. Delivering a placenta leaves behind a wound on the uterine wall roughly the size of a dinner plate.
Wow. A dinner plate.
Right. So by 6 weeks, the medical system primarily just needs to verify that this massive internal wound has closed over, that it's epithelialized, and the risk of a catastrophic hemorrhage or systemic infection has passed.
Which, I mean, that makes sense from a triage standpoint. You want to make sure the patient's safe.
Yeah.
But the messaging around it is where the disconnect happens.
Oh, completely.
It sounds like taking your car in for a state inspection, and the mechanic just pops the hood to see if the engine block is currently on fire.
That is a perfect way to describe it.
Right. And if there are no flames, they stamp your paperwork and say you're cleared to drive. But they never bothered to check if the steering column is actually connected or if the brake pads work.
What's fascinating here is how that basic triage check completely overlooks functional pelvic floor mechanics. Medical clearance at 6 weeks signifies you are out of the acute danger zone, period.
Right. It doesn't mean you're fixed.
Exactly. It in no way implies your muscles, ligaments, and connective tissues have returned to their pre-pregnancy tensile strength.
Which brings us to the core of the sources. I was reading through that Royal Australian College of General Practitioners review, and they make a very sharp distinction between pelvic organ prolapse POP and vaginal laxity.
Yes, this is a crucial distinction.
How do the clinical guidelines actually separate the two?
They separate them by structure versus sensation. So, pelvic organ prolapse is an anatomical event. The pelvic organs, like the bladder, the uterus, or the rectum, they physically descend into the vaginal space because there's a loss of support.
So a doctor can actually see that happening.
Yes. A physician can see this. They measure it using a standardized clinical tool called the POPQ system, which stands for pelvic organ prolapse quantification.
Okay, so how does that actually work in an exam room?
The doctor essentially uses a grid system. They measure 9 specific points in the vagina relative to the hymen using centimeters. If the bladder is bulging, say, 3 centimeters past the hymenal ring.
That's a quantifiable prolapse.
Exactly. It's structural. It goes on a chart.
But the sources define laxity entirely differently. It isn't a structural bulge. It's a subjective feeling.
Right. It's what the patient is experiencing day to day.
Women report a feeling of looseness, or a noticeable lack of friction during intimacy, or, tampons literally slipping out. And the RACGP data shows this sensation affects roughly 48% of women.
Yeah, nearly half the population who gives birth vaginally.
It is a massive number.
It is. And the overlap between the two is where the diagnostic confusion happens. Because a patient can experience profound laxity without having a measurable prolapse.
So she goes in for her 6-week check, hoping for answers.
Right. The doctor performs a standard speculum exam, does that POPQ assessment, and finds no bladder or uterus descending. The structural grid looks totally fine.
So what does this all mean? If a woman feels this physical looseness, but the doctor tells her she has zero prolapse and her anatomy is completely normal, is the medical system essentially telling her it's in her head?
Unfortunately, yeah. That is often the implicit message women receive. But the imaging research completely refutes it.
Thank goodness for the imaging research.
Seriously. The work by Dietz and Van Delft proves that laxity is often the result of severe physical trauma that a standard visual exam simply cannot detect. The primary culprit we really need to focus on is an injury called levator avulsion.
I want to spend some time on this because understanding the biomechanics of the pelvic floor seems like critical here. The levator ani is the main muscle complex, right? And the sources specifically highlight the pubirectalis muscle.
Yes. So the pubirectalis is a U-shaped band of muscle. It originates on the pubic bone, loops around the rectum, and forms a sling.
Like a hammock holding everything up.
Exactly. It holds the pelvic organs up against gravity. And more importantly for our topic, it maintains the closure of the vaginal hiatus. During a vaginal delivery, this specific muscle undergoes unprecedented mechanical stretching to accommodate the baby.
The numbers in the academic studies on what actually happens to that muscle are shocking. What percentage of women are experiencing a tear here?
The imaging studies indicate that levator avulsion happens in 13% to 36% of first-time mothers.
Wait, up to a third?
Up to a third. And we are talking about a catastrophic tear where the pubirectalis muscle is literally ripped off its attachment point on the pubic bone. It completely disconnects from the pelvis.
The APOPS, the Association for Pelvic Organ Prolapse Support, gives a biomechanical analogy for this that made it instantly click for me.
Oh, the shoulder one.
Yeah. Imagine your shoulder's deltoid muscle. If half of that muscle was severed or torn off your collarbone, you wouldn't be able to lift your arm against gravity. The muscle simply isn't anchored across the joint anymore to generate force.
That is exactly the mechanism of an avulsion.
Yeah.
Because the pubirectalis is detached from the bone, the levator hiatus, the gap it is supposed to keep closed, widens permanently.
And that physical widening is the root cause of the laxity sensation.
Right. The structural support is just gone.
But wait, if we go back to the car inspection analogy,
Yeah.
the mechanic might miss the steering column, but a torn muscle seems like a massive injury to overlook. If up to a third of first-time mothers are walking around with a muscle sheared off their pelvis, how does a standard speculum exam miss it?
Well, a speculum exam looks at the mucosa, which is the surface tissue of the vagina. The levator muscles are hidden beneath that surface layer.
Okay.
And the mucosa stretches incredibly well and heals very quickly. The episiotomy stitches dissolve, the surface skin knits back together, and to the naked eye, everything looks perfectly intact. The doctor sees a healed surface wall.
But they can't see behind the wall.
Exactly. They cannot see that the structural muscle behind that wall is detached.
It's like looking at a suspension bridge from a mile away. The road surface looks perfectly flat and paved, so you assume it's safe to drive on, but you can't see that the main steel support cables underneath have completely snapped.
A very apt comparison. The road will hold until you put weight on it. And that is why an avulsion doesn't just cause laxity. It creates a massive risk factor for developing severe pelvic organ prolapse years later. The suspension cables are broken, so gravity eventually wins.
The clinical data lists some specific risk factors for this kind of avulsion, right? Using forceps during delivery highly increases the risk, which, that makes mechanical sense given the rigid metal and the forces involved.
Definitely. A larger baby head circumference is another obvious one.
But the sources noted something surprising about epidurals.
Yeah, the research indicates that having an epidural is actually a protective factor against levator avulsion.
That feels so counterintuitive. You would think not feeling the area would lead to more damage because you can't feel yourself tearing.
You'd think so, but it comes down to the biomechanics of the pushing phase. Tissues need time to stretch. If a mother doesn't have an epidural, the maternal urge to push can be overwhelmingly strong before the pelvic floor muscles have fully relaxed and thinned out.
So they push too hard too fast.
Right. An epidural often slows down that second stage of labor. It prevents the patient from overriding the natural stretch reflex too early, allowing the fetal head to descend slower. So the puborectalis muscle elongates and accommodates, rather than snapping under sudden pressure.
Here's where it gets really interesting, though. If the standard visual check fundamentally misses this hidden trauma, what are the actual diagnostic tools that find it? Because a pelvic floor physiotherapist seems to approach this from a completely different universe than a standard GP.
They really do. And it starts with specialized palpation. An expert examiner doesn't just look, they feel for the levator urethra gap.
What exactly are they feeling for?
In an intact pelvic floor, the space between the urethra and the puborectalis insertion point is very narrow, barely admitting the tip of an index finger. If a woman has an avulsion, that gap widens significantly.
Wow.
A trained physiotherapist will ask the patient to contract her muscles, and the examiner will physically feel a blank space on the pubic bone where contracting muscle tissue should be.
That's incredible.
Hmm.
But palpation is still somewhat reliant on the examiner's skill level, right? The sources emphasize that imaging is the absolute gold standard here. Dates' research relies heavily on 3D and 4D transperineal ultrasound. How does a 4D ultrasound show a hidden muscle tear?
So traditional 2D ultrasound just gives you a flat slice. 4D transperineal ultrasound captures a volume of tissue over time. The transducer is placed on the perineum, and it reconstructs the entire pelvic floor in a three-dimensional model while the patient is actively contracting or bearing down.
So they can see it moving in real time.
Exactly. The clinician can literally rotate the image on the screen and look at the pubic bone to see if the muscle is anchored or floating free.
That's wild. But even with 4D ultrasound, the Semantic Scholar study in our stack compared it directly to MRI, and the difference in detection rates was massive.
It was a huge difference.
Yeah, ultrasound caught avulsions in 27.1% of cases, but MRI detected trauma in 63.4% of the cases. What is the MRI seeing that the sound waves are just missing?
Well, ultrasound relies on sound waves bouncing off dense tissues, which is great for obvious structural gaps. MRI, however, uses magnetic fields to interact with the hydrogen protons in the body's water molecules.
Giving it a better look at the soft stuff.
Precisely. It gives unparalleled contrast resolution for soft tissues. And MRI doesn't just see the complete avulsions. It highlights edema, inflammation, partial tears, and asymmetrical muscle thinning that haven't fully detached yet. It essentially maps the subtle collateral damage of birth.
And beyond the imaging, the sources detail these diagnostic questionnaires like the ICI-QVS and the EPA-QPF. How do a bunch of questions functionally help diagnose something structural?
Right, so the ICI-QVS stands for the International Consultation on Incontinence Questionnaire Vaginal Symptoms, and the EPA-QPF is the Electronic Personal Assessment Questionnaire for the pelvic floor. These aren't just generic surveys.
Like a 1 to 10 pain scale.
No, much more advanced. They use multidimensional scaling to convert subjective feelings into quantifiable clinical data. They ask highly specific questions about vaginal drag, friction during intercourse, and quality of life impacts, and generate a numerical score.
So they turn feelings into hard numbers.
Yes. This allows a clinician to track a sensation like laxity with the exact same mathematical rigor they track a structural prolapse. If we connect this to the bigger picture, the contrast in how we handle diagnosis is just jarring. Think about a major sports injury.
Oh, this is a great comparison.
Right. If an athlete reports a sensation of instability in their knees, say, the joint feels loose when they cut or pivot. They don't just get a visual check of the skin, they get an MRI to check the ACL, and they are handed over to a specialized rehabilitation team.
But when someone experiences a biomechanical trauma during childbirth that results in a muscle literally shearing off a bone, they get a visual check for surface healing and are sent on their way.
Exactly. A pelvic floor physiotherapist, however, assesses the postpartum patient exactly like that recovering athlete. They evaluate muscle endurance, bilateral symmetry, scar tissue mobility, and how the pelvic floor integrates with the diaphragm during breathing.
Which brings us to the actual solutions. Because if the imaging proves the puborectalis muscle is completely detached, doing standard Kegels at a stoplight isn't going to magically reattach it to the bone.
Not at all.
What does the evidence say actually works for vaginal laxity?
The clinical consensus prioritizes conservative, targeted rehabilitation. The NICE guidelines and physiotherapy standards outline a baseline timeline. It takes a minimum of 10 to 12 weeks for skeletal muscle to begin undergoing true hypertrophy, which is actual structural strengthening after an injury.
Meaning the 6-week clearance mark is biologically premature for anyone expecting their muscles to be fully functional again.
Completely premature. The first-line treatment is pelvic floor muscle training, or PFMT, under the guidance of a specialist.
What does that look like in practice?
Well, if there is an avulsion on one side, the physio designs a protocol to hypertrophy the intact muscle fibers to compensate for the broken sling. This requires a dedicated program running anywhere from 6 to 16 weeks to achieve meaningful neuromuscular adaptation.
But the sources also point out that laxity isn't exclusively a postpartum issue, right?
Yeah.
Menopausal women experience it through a completely different mechanism called genitourinary syndrome of menopause, or GSM.
That's right. In the case of GSM, the laxity isn't caused by a torn muscle at all. It is caused by the systemic drop in estrogen. Estrogen is what maintains the thickness, elasticity, and blood flow of the vaginal epithelium.
So what happens when it drops?
When estrogen drops, the tissue itself thins out and loses its rugae. Those are the folds that provide friction.
And the treatment for that is localized, right?
Yes, local vaginal estrogen is the gold standard for GSM. By applying estrogen directly to the tissue, it restores the cellular architecture, plumping the epithelium and replenishing glycogen, which often resolves the sensation of laxity without requiring any structural muscle rehab.
So we have evidence-based solutions. We have targeted biomechanical rehab for trauma and cellular restoration via local estrogen for menopause. But we have to look at what happens when women fall into that diagnostic gap at 6 weeks.
Yeah, the gap is where things get dangerous.
If they're told everything is normal but they feel broken, they naturally look for alternative answers. And the stack of sources contains very strict warnings about energy-based devices.
Energy-based devices, or EBDs. These utilize lasers or radiofrequency. They are heavily marketed for vaginal rejuvenation or tightening.
How are they supposed to work?
The theoretical mechanism is that applying thermal energy creates controlled microtrauma in the vaginal tissue, prompting a healing response that stimulates new collagen production.
I mean, it sounds like a quick fix to shrink everything back to normal, but what does the regulatory data actually say?
The clinical reality is highly scrutinized. The NICE guidelines currently consider these devices investigational, noting a severe lack of robust long-term efficacy data. The U.S. FDA has gone further, issuing explicit safety warnings that these devices can cause severe burns, permanent scarring, and chronic pain during intercourse.
And the UK Women's Health Clinic guide in our stack noted a major regulatory shift recently, too. In 2025, Australia's Therapeutic Goods Administration reviewed the evidence and outright canceled the approvals for these vaginal rejuvenation devices.
Yeah, they are no longer considered standard care down there at all.
It just highlights this systemic loop, A patient reports a functional issue at 6 weeks. The standard visual exam misses the hidden avulsion. The patient is told her anatomy is normal.
Which is incredibly dismissive.
Exactly. Frustrated and seeking a solution for a very real loss of quality of life, she turns to commercial laser clinics promising rejuvenation. She steps away from evidence-based physiotherapy and right into treatments that regulatory bodies are actively warning against.
It perfectly demonstrates what happens when medical protocols prioritize acute triage over long-term functional recovery. The gap in the standard of care leaves a vacuum.
So, to summarize the mission of this deep dive, yes, a standard 6-week postnatal check absolutely misses vaginal laxity.
Every time.
It misses it because the check is structurally designed to verify that a placental wound has healed and that no organs are visibly descending. It is not designed to detect a levator avulsion, and it is not equipped to measure functional muscle recovery.
A clean bill of health at 6 weeks means your life is not in danger. It does not mean your biomechanics are fully restored.
So the biggest takeaway for you listening is self-advocacy. If you are experiencing that sensation of laxity, if you feel a loss of support, the data proves it is not in your head. Do not let a quick visual exam be the end of the conversation.
Don't.
Seek out a qualified pelvic floor physiotherapist who will utilize the right diagnostic tools, assess the hidden muscular structures, and build a targeted recovery protocol.
This raises an important question, one that really challenges how we structure maternal health care globally. If we know that childbirth routinely causes structural injuries comparable to major athletic traumas, why do postpartum protocols still conclude at 6 weeks with a visual check? What would the landscape of women's health look like if obstetric recovery was funded, researched, and rehabilitated with the exact same rigor as elite sports medicine?
Imagine a system where the biomechanics of the pelvic floor are treated with the same urgency as a quarterback's knee. Until that becomes the standard. Remember, if the mechanic says the engine isn't on fire, that's great news. But if you know the steering wheel is disconnected, don't let anyone tell you the car is fine to drive. Keep digging into the data and demand real functional answers. Thanks for joining us on this deep dive.